And the next group of drugs is a calcium channel blocker, very high yield group, and they are like subdivided into two groups, subgroups like the amlodipine, clifidipine, nicardipine, nifedipine, nimodipine. These all are like dihydropyridines, which act on the vascular smooth muscle. In the contrary, like diltiazem and verapamil, they are like are non-dihydropyridine drugs. They will act on the heart. So, and as we have just said, they will block the voltage dependent L-type calcium channel blocker, and so they'll decrease muscle contractility. And as we have just said, the vascular smooth muscles, the amlodipine and the nifedipine action is more. So, and these are the dihydropyridine drugs. On the contrary, on the heart, the verapamil and the diltiazem. As we have non-dihydropyridine drugs action on the heart. So, as we have just said, so the dihydropyridine, except nimodipine, are treated used in hypertension and angina. And the vasospastic angina, you have to know, like the vasospastic angina, essentially, very high yield to know that calcium channel blocker are used in vasospastic angina, an vasospasm that goes on its own. So. Calcium channel blocker, very high yield to be used in vasospastic angina. Raynaud's phenomena, of course, also is a common condition that calcium channel blocker are used. The dihydropyridine ones, all the vascular ones. Nimodipine is also a dihydropyridine, also aka a vascular acting drug, but it is used in like in subarachnoid hemorrhage. So in subarachnoid hemorrhage, there's we feel like delayed ischemia, like vasoconstriction that occurs in the area of the subarachnoid hemorrhage, which is like we give nimodipine, a special kind of dihydropyridine, very high yield to know that it is used in subarachnoid hemorrhage, the nimodipine and the nicardipine or clevidipine, which are also they are used in hypertension, but they are peculiar for their use in like an hypertensive urgency or emergency. Nicardipine and the clevidipine, very high yield, the nicardipine and the clevidipine, and also the like non-dihydropyridines, of course, used in hypertension, angina, atrial fibrillation, and atrial flutter. So we add like the cardiac action, atrial fibrillation or atrial flutter, verapamil, and diltiazem. So adverse effect, the calcium channel blocker, gingival hyperplasia, very famous. And you have to know that. And the hydropyridine also very high yield to know that they may cause like peripheral edema when you have like patient treated like antihypertensive dihydropyridine and have like peripheral edema, you have to revise their drugs and the flushing and the dizziness. While the non-dihydropyridine who are that work on the heart may have like cardiac depression, AV block, and hyperprolactinemia with verapamil. Watch out for that, and constipation. So they have like constipation. So the next drug is hydralazine. Not very high yield to know, but it increased like cyclic GMB as we in the illustration, we increase cyclic GMB like smooth muscle relaxation, and it has like vasodilatation of the arterioles more than the veins. So it is more an afterload reduction. So remember nitrates, we have just said that it acts on the veins more than the arteries. And from this comes the concept of like combining hydralazine with nitrate. So like with hydralazine, you're causing like more arteriolar dilatation. With nitrates, you are causing more venous dilatation. So you are just combining both with the combo of hydralazine plus nitrates. So the clinical use uses in severe hypertension, in acute hypertension, hydralazine. And remember, we said like hydralazine used in pregnancy. Remember, hydralazine is one of the safe drugs to be used in pregnancy, and also frequently administered with beta blocker to prevent tachycardia or reflex tachycardia. The same concept of combining beta blocker with nitrates to prevent reflex tachycardia, and also heart failure with organic nitrates, as we have just said. So the adverse effect of hydralazine is a compensatory tachycardia, So you will not give in the angina or coronary artery disease. You are with this reflex of tachycardia, you're gonna put so much strain on the heart. So in angina or coronary artery disease, the patient is coming to you with coronary artery disease. Don't give him hydralazine in this acute attack, and may cause fluid retention or headache or angina, as we have just said. And hydralazine is very famous for causing drug-induced lupus. Just to memorize, hydralazine causes drug-induced lupus, very high yield. And for the hypertensive emergency, you have to know that labetalol, beta blocker, clevidipine, calcium channel blocker, phenol-dopam acting on D1 receptor, and the nicardipine, nitrobruside infusion. You just know like vasodilator, nitric oxide. So just to memorize that labetalol, clevidipine, phenol-dopam, nicardipine, and the nitroprostide, all of them are used in emergency. So you have like the patient coming use blood pressure over 180 or above over like 120, for example. So this patient is having like hypertension emergency. So having like associated chest pain, like confusion. So you have to start with one of these drugs, labetalol, clevidipine, phenol-dopam, nicardipine, and nitroprostide infusion, for example. So the for the nitric oxide, like a short-acting vasodilator and acts on the arteries in the vein. So remember, so for the one who acts on the vein is the nitric oxide, or the one who acts more on the vessels or the arterioles is like hydralazine, and for nitroprostide it acts on equally on arteries and veins at the same concept, increase cyclic J maybe for the direct release of nitric oxide, and watch out for cyanide toxicity. So with when you infuse it for a long time, watch out for cyanide toxicity with nitrobruside infusion, one of the common drugs used in hypertensive emergency. Also like phenol-dopam. So phenol-dopam is a dopamine D1 receptor agonist. So dopamine D1 receptor agonist is like everywhere in the coronary, the peripheral vessels, renal vessels, pancreatic vessel. Very characteristic for the D1 receptor. Very like everywhere. You have to know that coronary, peripheral, renal, splanchnic. So it's like agonist on this receptor, phenol-dopam, decreases blood pressure, increases natriuresis. So and used post-operatively as antihypertensive agent, and they can cause like hypotension, tachycardia, and flushing. So hypotension, reflex tachycardia, nothing new. So anti-anginal therapy. So for anti-anginal therapy, as we may go give nitrates and give beta blocker as anti-anginal therapy to just block out the reflex tachycardia with nitrates. So our goal at the end is like reduction of the oxygen consumption, which is minute oxygen consumption by decreasing like one of or more of the determinants of MVOs, like end-diastolic volume or the blood pressure, heart rate, contractility. We our aim is like to decrease one or more of this. So for the end-diastolic volume, the nitrates are gonna decrease the end-diastolic volume, cause decreased preload or cause like venodilation, logically to decrease the end-diastolic volume. The beta blockers, on the contrary, has no effect or like maybe increase the end-diastolic volume because it will give the heart more time to just relax and accommodate blood. So the accumulation of them is like no effect or like decreasing. So this is nitrates and plus beta blocker. Blood pressure, of course, nitrates and the beta blockers, or both of them antihypertensive, they will gonna decrease, and the cumulative effect is the decrease, of course. And contractility and heart rate is the difference lies here. So the contractility and the heart rate, beta blockers, they will gonna decrease the contractility and they're gonna decrease the heart rate. Everyone knows that. But nitrates, on the other hand, acts on the vessels. So the heart is gonna reflect as a reflex, increasing contractility and increasing heart rate. So the contractility and the heart rate will gonna increase with the nitrates as a reflex. So you are essentially giving like beta blocker with nitrates to just wean off these effects. So they were opposite, gonna be opposite to each other. So at the end, you will have little or no effect. This is like the whole idea of giving like beta blockers with nitrates. So ejection time, of course, Beta blockers will increase the ejection time, so it is gonna slow down the heart, will give it more time to just accommodate blood and eject the blood. So beta blocker will gonna increase ejection time. On the contrary, the nitrate, of course, is the opposite. It's gonna cause vasodilation, reflex tachycardia, not giving the heart more time to just like eject blood. It's gonna decrease the ejection time. Also, of course, the end is like little or no effect. So the oxygen minute oxygen extraction or minute oxygen consumption, sorry, is gonna be decreased with it with nitrates or the beta blocker, and the cumulative effect is gonna be so much decreased. So this is for anti-anginal therapy with nitrates. So ranolazine, not very high yield drug, but just know that its mechanism acts on a very specific time of the cardiac size, like the late phase of inward sodium current, and thereby there's like inward sodium current. It acts on just the late phase of it, and consequently, this will gonna decrease the diastolic wall tension. So it is uh, used in angina, but like nitrates or beta blocker is not gonna affect either heart rate or beta or blood pressure. It acts on like a very specific stage, which is like late phase of inward sodium. So this will decrease the diastolic wall tension, and this is the whole idea about ranolazine, decreasing the diastolic wall tension. If we decrease the diastolic wall tension, we're gonna decrease the oxygen consumption. So this is gonna be used in like refractory angina, where we decrease the heart rate and the blood pressure and all of the work of the heart, and there is still angina. We're gonna work on decreasing the diastolic wall tension through ranolazine. So for that, and it also comes with its adverse effects like constipation, dizziness, and headache and nausea. So this is for the ranolazine. So ranolazine and sacubitril, you remember, used with ARBs in heart failure. So it's like an aberylsine inhibitor, which prevents like the degradation of bradykinin. When prevents the degradation of something, it will increase its level. So we'll have like so much bradykinin, natriuretic peptides, kind of vasodilator. We also have like some increase also in angiotensin 2 and substance B. So the cumulative effect of this is gonna be like vasodilation due to like bradykinin and the natriuretic peptide. So and the decrease in the extracellular fluid volume. So as we have just said, used with valsartan, an ARB to treat heart failure, reduce the ejection fraction, HRF. You're gonna combine like sacubitril as an aberylsine inhibitor with ARBs, such as valsartan, sacubitril, the very famous drug used in HFrEF. So for the adverse effect for sacubitril, of course, it's a vasodilator caused like hypotension, and it's gonna combine like aldosterone antagonists like in hyperkalemia. It's gonna be more like aldosterone antagonist in the hyperkalemia part, and it's gonna be like ACE inhibitor in the cough part. So you have to watch out for cough and hyperkalemia. Sacubitril can cause both cough as ACE inhibitor and hyperkalemia as aldosterone antagonist. So hypotension, hyperkalemia, and the cough. And you contraindicated with ACE inhibitor because when doing so, you are putting the patient in angioedema. So if you concentrated, you are combining him with ARB, not ACE inhibitor. We're combining him this drug with like valsartan as an ARB sacubitril, not ACE inhibitor sacubitril. Very dangerous to give like ACE inhibitor with sacubitril. As both drugs will increase like bradykinin, so angiotensin 2 is gonna normally going to be an active or natriuretic peptide, but neprilysin inhibitor is gonna stop that and will keep angiotensin 2 and the natriuretic peptides in work. It's gonna increase its level, so it's gonna increase the natriuretic peptides, the angiotensin 2, the bradykinin, the substance B, gonna increase all of that, and the cumulative effect is vasodilation, and the use of it is with valsartan as ARBs to treat heart failure, reduce ejection fraction. So, and this is for at the end, this is all for the hypertensive drugs. and like the different kind of the work of them contra indication and adverse effects. I hope you guys learned a lot today and enjoyed our episode today, and see you in the next episode.